All right, awesome. So today, based on your vote, I'm going to be talking about salivary gland. And so salivary gland is going to include just a very basic overview of normal salivary gland histology, a couple non-neoplastic entities, but most of it is going to be the tumors, because that's the most thing we see in salivary gland. So there are three major glands: the parotid, the submandibular, and the sublingual. And there are many, many minor salivary glands throughout the upper aerodigestive tract: tongue, palate, all the way down through the trachea, larynx, etc. So we see these kind of seromucinous glands in all of those locations. Just as a reminder, the parotid is essentially entirely composed of serous acini, which are purple and have the zymogen, the pre-digestive enzyme granules in them. The submandibular is mixed serous, which are purple, and mucinous, which are these pale. And the sublingual and minor salivary glands tend to be predominant, and other minor salivary glands are predominantly mucinous. So again, mostly this whitish mixoid material, of course. So the serous are going to be the digestive enzymes, and the mucinous is just going to be the mucin to lubricate those tracts. One of the common non-neoplastic entities we see is a mucocele. As you can see, here's a very prominent clinical example on the floor of mouth. But often they just present as small kind of fluctuant masses on various sites of the mucosa, and they are pseudocystic reactions to extravasated mucin, generally from biting lips or other trauma. Once they become big, like this bottom left picture, they're called a ranula, which comes from the kind of phenomenon of the chin of the frog where it bulges out. And a plunging ranula is when that mucocele plunges down through the mylohyoid muscle to involve the neck. So these are basically just pseudocystic spaces containing mucin, lined by these small macrophages that digest the mucin, or mucophages. The next benign thing is a stone, right? A cyalolith, or I should say the next non-tumor thing. So this is most common in the submandibular gland, but can really be present in any duct of any salivary gland. Different calcium phosphates and salts kind of organize around a central nidus, such as bacteria or mucus or even epithelial cells, creating this stone, creating, of course, a blockage with mucin mucin collection. Generally happens to swell at mealtime. Here's a radiographic example of what a stone might look like as opaque. The other biopsies we get for non-neoplastic diseases are for Sjogren's syndrome. So occasionally when a person manifests with some kind of dry mouth that is imperfect by serologic testing, the patient may undergo lip biopsy. And so we will look for inflammation within the salivary gland, being one focus of 50 or more lymphocytes, and we score the most inflamed 4 millimeter squared field, which is essentially a 10x microscope objective. Here's a score as published by our colleagues here at the U of C a number of years ago. But basically this is what it looks like. So a nice discrete cluster of 50 or more lymphocytes would represent a focus. And this is essentially thought to be predictive of some kind of Sjogren's syndrome in the absence of good serologic evidence of SSA or SSB antigens or antibodies. All right, atrophic change in salivary glands can happen, especially in the setting of injury or chemoradiation, which of course at U of C, we see a lot of patients who've undergone chemoradiation for other head and neck cancers. The gland can undergo fatty replacement as seen at the bottom. It can undergo fibrosis, inflammation, but generally the ductal lobular architecture is preserved. You can see a duct here with acini still clustered around this central duct. And sometimes in the context of atrophy, the ducts and acini also undergo cyalometaplasia, which is basically squamous metaplasia of salivary ducts. So cyalo meaning the salivary, so squamous metaplasia of salivary. Often it can present as a localized ulcer on the palate as seen here. However, it can just be a microscopic finding in an otherwise radiated patient, but you still see the ductal architecture preserved with some goblet cells. You may see some intraluminal neutrophilic debris. You may see the squamous metaplasia extending into the peripheral acinar units. So that was basically the non-neoplastic entities. Does anybody have any questions or comments on the non-neoplastic entities before we move to the tumors? Okay, so in the setting of salivary tumors, benign tumors occur much more frequently than malignant ones. The most common site of all tumors would be the parotid gland. The site with the highest rate of malignant tumors is interestingly the sublingual gland. But when you think about salivary gland carcinomas, they represent only a very small minority of head and neck cancers overall, about 6%. The most common tumor that we will see is the pleomorphic adenoma, which is benign. Therefore, the most common benign tumor is also pleomorphic adenoma, followed by Warthin. The most common malignant is mucoep, followed by adenoid cystic, and we'll talk about all of those. Biopsy, of course, is the preferred method for screening, and not really core biopsy as much as a fine needle aspiration biopsy from our cytologists. So just like the thyroid has the Bethesda system, salivary gland now has the Milan system, which is lumped into essentially non-diagnostic, so must repeat, non-neoplastic, like sialadenitis, can be followed up. Some kind of atypia of undetermined significance, meaning the cells are atypical, but I can't even tell if they are a neoplasm. Generally will also get a repeat biopsy or surgery. And then there's the neoplasms. So this is either a benign or an uncertain neoplasm. Then there's a suspicious for malignant and an overtly malignant. And again, your risk of malignancy on resection for all of those categories steadily increases. But essentially, anytime you get a diagnosis of a salivary neoplasm on FNA, most of these patients go for surgery. Perhaps the exception to that might be if you get an obvious Warthin tumor on FNA and it is not causing any problem for the patient and it has a very low likelihood of doing anything worse. Those may get observed, but other salivary gland tumors generally get resected for definitive diagnosis as well as for preventing malignant transformation. Here's my kind of algorithmic thought about salivary neoplasms. And so because mostly we're talking about the parotid, but of course this could apply to any salivary gland. We basically want to say, is this a primary tumor of that gland or is this a metastasis to that gland? And the reason this is so important is because there are so many lymph nodes in and around the major salivary glands that you can get metastases to those lymph nodes that mimic primary glandular processes. So it's always important to keep in mind that that could be an option. Once we tell as pathologists that the tumor is a primary of salivary gland, we certainly want to tell whether it's benign or malignant. If it's malignant, we certainly want to differentiate between low and high grade. And in fact, this is the key here. Because a benign salivary neoplasm and a low-grade carcinoma both are essentially treated with surgical resection with negative margins and clinical observation. These patients usually do not undergo neck dissection. Since treatment of benign and low-grade malignant is the same, this is kind of a good thing for me as a surgical pathologist because I often do not need to make a definitive diagnosis on biopsy between a benign and a low-grade malignancy, especially if it's a challenging diagnosis with overlapping histology. However, if it is a high grade, I would want to communicate that because the patient might then undergo neck dissection up front in that initial surgery. So things we want to think about for metastases are going to be things like squamous cell carcinomas of the skin that can metastasize, especially to the periparotid lymph nodes, and certainly things like melanomas. We've seen a number of these, both of these in our clinical practice. So once the decision is made to operate on these patients, our role as pathologists are to confirm a salivary primary versus a metastasis, as I said, confirm low versus high grade. Grade, as I said before, is often more important than specific histologic subtype of the salivary carcinoma. But of course, because there are so many subtypes with so many possible behaviors, we do try to histologically subtype them, and that's what we're going to do in the rest of this lecture. We do want to comment on the margins and, of course, the TNM stage if it is a malignancy. So here's all of the tumors. I'm not going to go over this chart, but it's for if there's any pathologists on this call who want to review this. The way I think about these is, you know, there are benign tumors, there are malignant tumors. Some are essentially only benign that do not have malignant counterparts. Some are only malignant that do not have benign counterparts, and some have benign and malignant versions, right? So pleomorphic adenoma, carcinoma X, basal cell adenoma, basal cell adenocarcinoma, all of these have morphologic and genetic similarities, and so I like to think about things in that way. I also like to think about tumors in terms of how many cell types they have. Do they have one cell type? Do they have two cell types? Or like mucoep, do they have three cell types? And this will help you kind of organize your thought process for diagnosis. And then of course, molecular. So we don't necessarily use molecular frequently in diagnosis because again, it may not matter extremely, but if there is a question between a benign and a malignant tumor in which genetics will be helpful, such as, you know, a low-grade mucoep versus a benign cystic lesion, rearrangements like mammals, et cetera, can help at least point you to a malignancy, if that makes sense. All right, so what is my approach overall to salivary tumors with that chart in mind? So I always want to examine the outer border. Is it circumscribed? Both benign and low-grade malignant can be circumscribed. But obviously an infiltrative growth pattern is the best indicator of malignancy. So in fact, the low power appearance of a salivary tumor is very important because a benign tumor really should not be infiltrative. I examine the number of cell types, as I said, generally one or two. So the single cell types are going to be tumors of either completely epithelial cells or tumors of completely myoepithelial cells. Then there are the biphasic tumors that have both epithelial and myoepithelial cells. And lastly, we'll kind of examine the general morphologic pattern, meaning is it very blue, basaloid, cribriform, or tubular? Is it very cystic with secretory or mucinous material? And then is it sort of solid to nested? So all of these three features come into play to help us make a diagnosis. But of course, our standard hematoxin and eosin stain will be our guide with select use of IHC and genetics. Questions or comments before I get into the individual tumors? Okay. So of course, if you have anything, feel free to put it in the chat. So these are we're gonna start with the benign tumors, and we're gonna proceed on to the malignant counterparts of those benign tumors. This is just a reminder of how many cell types each of those have. You may read in the older literature about monomorphic adenomas. So monomorphic adenomas were basically anything that was not a pleomorphic adenoma. So that fell under things like a myoepithelioma, an oncocytoma, basal cell adenoma. We don't really use monomorphic adenomas anymore because we have specific histologic and genetic differences between them, so we actually call them what they are. So starting with a PA, the gross appearance of a PA is very characteristic. It should have a well-defined edge. It may not have a true tumor capsule, but certainly a clear border. And it has this usually kind of white or glistening cut surface that resembles cartilage because, as you will see, the matrix of PAs tends to be chondroid or chondromyxoid. And so you can see there's a little bit of variability here, yellow to white, but there's variability in a PA. So this is very characteristic of PA. Radiographically, I'm not sure. You guys can tell me better what PAs look like. and if they resemble cartilage in their radiographic appearance. So why pleomorphic adenoma? So it is not pleomorphic in terms of cytologic atypia, right? Like nuclear enlargement, hyperchromasia, angulated nuclei, those are cytologic pleomorphism features. This is more polymorphous or heterogeneous in terms of the morphology and the architecture, even as you saw on this cut gross image, right? So heterogeneous, polymorphous, rather than truly cytologic pleomorphism. So just a weird misnomer. This is one of our biphasic tumors with epithelial and myoepithelial cells in this myxoid to cartilaginous matrix. You can see clearly this bluish pale myxoid matrix, and within it you can see on the right these bilayered ducts, right? So these more pink epithelial cells in the center, surrounded by the basal myoepithelial cells at the periphery, characteristic of pleomorphic adenoma. The cells in the stroma here are thought to actually be modified spindled myoepithelial cells, so similar to these guys out here, but just embedded singly in stroma. Myoepithelial component of pleomorphic adenoma can be also very varied, so it can be very cellular and spindled. It can be plasmacytoid, almost resembling a plasma cell, and they can be very small and inconspicuous as well. You may see tyrosine crystals in the stroma of these. That is a nice feature of PA that we don't really see in other salivary tumors, but we don't always report it because it's not very, I don't know, particular. I know that Dr. Ganat was looking for some of the cases with tyrosine crystals, but unfortunately we don't really report them, so that would be very, very hard to identify, but this is what they look like, kind of little florets, pink florets, usually within the myxoid stroma. Things PAs can do, it's important to think about this, therefore this is why we resect these, right? So first, they can recur after incomplete excision. Hence, primary clean margin negative excision is the most important treatment we can give for a PA. They can metastasize in a bland cytomorphology, so-called benign metastasizing PA. This is very controversial, but theoretically it can happen. But most importantly, it can transform to a high-grade carcinoma. Usually with infiltrative destructive growth, it can resemble any type of salivary carcinoma and is certainly a high-grade cancer. There is also a thing called in situ or intracapsular carcinoma. That's like the incipient pre-invasive version of the cancer, right? So this is nuclear atypia and mitoses confined to the tubules, does not extend beyond the main margin of the tumor. These tend to have good behaviors, and I'll show you histologic features of all of these entities. So recurrent PA tends to look like multiple small lobules in the stroma, kind of this buckshot appearance. So if we see this histologically, this is very classic for recurrence. So this patient has had a PA before, they've been operated on before. This is not what a de novo PA looks like, these small, small, small nodules. Carcinoma X happens in about 6% or so of all pleomorphic adenomas and is about 12% of all salivary cancers. By definition, it's either a malignancy with evidence of an adjacent concurrent benign PA or as a malignant tumor in the same spot that a prior benign PA was resected. Most of these, or many of these, if they are in fact invasive, do metastasize, but if they are non-invasive, tend to have better prognoses similar to benign. So this is the in situ component where the tumor on low power still has a clean edge, right? There's a little bit of fibrous tissue and some glands out here. But when you look inside this cleanly edged tumor, you see that these bilayered ducts have severe cytologic atypia of the epithelial cells, nucleoli, mitoses, but they are still confined by this outer basal or myoepithelial cell layer. If left in the patient, this would eventually transform to an invasive cancer. In this case, it was caught in situ. You can see here evidence of the myoepithelial cells on P63 immunostains surrounding these atypical epithelial cells. So this is in situ. Then what happens is these cells break out of these ducts, break out of the capsule of the tumor and invade into the adjacent salivary stroma. This is invasive carcinoma X. You can see I've highlighted these tongues of invasive tumor extending into the normal parotid. And on the bottom right, this nodule, this circumscribed nodule, which is the residual scarred down hyalinized pleomorphic adenoma. You can still see evidence of residual, perhaps in situ ducts where my arrow is pointing. So if we look at these residual ducts on higher power, we will see evidence of that same in situ component, right? So here are the ducts with peripheral flattened myoepithelial cells, peripheral flattened myoepithelial cells, but the epithelial cells have severe cytologic atypia and mitoses, right? So this to me is good evidence that this is how it starts, right? This intraductal component that we see evidence for in this invasive cancer starts as this intraductal malignant neoplasm, and then it invades. Some pitfalls for the pathologists are, you can have various types of metaplasias or even fat admixed with the PA. You can have some mitoses or degenerative atypia, but you really shouldn't have nuclear pleomorphism, enlargement, prominent nucleoli, abundant apoptoses or mitoses, and certainly no significant destructive invasive growth. Okay, so genetics of PA, 70% of them have known molecular anomalies, namely rearrangements of PLAG and HMGA2 gene, listed here with their common partners. I won't really go over it, but just, those are the two genes involved. All right, so since PA was our most common tumor, we spent a little bit more time on it, but we'll go a little bit more quickly through the others. Remember how we talked about PA being a combination of epithelial and myoepithelial cells, and sometimes the myoepithelial cells can be very prominent and spindled. Well, if you have a tumor that's entirely of myoepithelial cells without any epithelial cells or ducts, these are called myoepitheliomas. In the salivary gland, they are very rare. It's thought that maybe they are just duct-poor pleomorphic adenomas. They should stain with both your epithelial and your myoid/myoepithelial markers. However, myoepithelial carcinoma is a known and specific entity that is histologically differentiated from benign myoepithelial tumors by infiltrative and destructive growth. They can transform from a PA. They can arise de novo. If they arise from a PA, they have PLAG rearrangements or HMGA2. If they are de novo and they have clear cell morphology, they can have EWSR gene rearrangements. Here's what they look like. They tend to be these large multilobulated lesions, often with central hyalinization or central necrosis. If you look at the cells at the periphery of those lobules, they are nests and cords of these plump eosinophilic myoepithelial cells in a mucinous stroma. Sometimes they have plasmacytoid or rhabdoid appearance, but again, you really shouldn't see any true bilayered ducts or any true epithelial cells. You may sometimes see small microcystic degenerative spaces. The second most common benign tumor, as I already mentioned, is Wharton. Grossly, these can look quite grungy, cystic to solid with this yellowish material. So if you all are ever doing a in-person FNA or a radiology guided FNA, you may aspirate this grungy, gross looking material. That could be evidence of a Wharton tumor. It's basically this degenerated cystic stuff in the center of these spaces. These, as we know clinically, can be multifocal. They can be bilateral, and that's commonly in patients who are smokers. Therefore, it is thought that perhaps these are potentially reactive rather than neoplastic because of this clinical manifestation of multifocality and bilaterality. Because these uptake, FDG, they are avid on PET scan, potentially because of either the lymphoid stroma or the high mitochondria content of the oncocytes in these epithelial cells. So, mostly we pick these up because patients are getting a PET scan for some other cancer, lung cancer, colon cancer, and something pops up in their parotid, right? And a lot of these patients are also smokers. And so they may just end up with a Wharton tumor in the parotid. All right. So here's what it looks like. Again, on low power, you can draw a line at the edge, very circumscribed. It's composed both, as I said, of this background of very dense blue lymphoid stroma and these small and large cystic spaces. The cystic spaces are lined by this pink epithelium, which is, as we call, oncocytic. So why oncocytic? So oncos literally means a swelling or sort of a quote unquote tumor, but in this case, the cells are swollen. The cells are swollen by mitochondria. You can see on EM, here's the nucleus, here's all the mitochondria, and therefore these cells are very, very abundant, large pink cytoplasm, also with cytoplasmic granularity because the mitochondria are kind of impart that speckled granular quality. So this is an oncocyte, and again, the mitochondria and the lymphoid stroma may account for the uptake of the FDG glucose and the PET avidity. If you have a tumor that is purely of oncocytes without lymphoid stroma, you may be allowed to call it an oncocytoma. So again, lack of lymphoid stroma, lack of cysts. Mostly this is a solid tumor. However, in elderly patients, you can actually see oncocytic metaplasia or hyperplasia that is not a single solitary tumor, as you see in these gross images. I'll show you what that looks like. So this is an oncocytoma with a clean border, purely composed of these eosinophilic oncocytes. Sometimes you can have some cytoplasmic clearing. And here's oncocytosis. So a patch here, a patch here, a patch here. This is very common in elderly patients. You can get transformation of one of these nodular oncocytic lesions to an actual dominant oncocytoma. But if you see them multiple, a little one here, there's another one here with clear cell change. This is just benign oncocytic metaplasia of the elderly. Oncocytic carcinoma is differentiated from benign, of course. This is a recurring theme, by infiltrative growth. Some can transform from oncocytoma, some are de novo. Neither oncocytomas nor oncocytic carcinomas have any specific genetics. Here's an example of the outlined border of an infiltrative oncocytic carcinoma. You can see there was a benign low-grade oncocytoma out here with a clean edge at the bottom, but then a lobulated infiltrative pattern with fibrosis at the opposite edge. You can have random, almost endocrine type atypia or random oncocyte type atypia. This should not affect your diagnosis of benign, malignant, or malignant grade. Oncocytes tend to have abnormally large nuclei with these prominent nucleoli, sometimes with inclusions, sometimes with random enlargement, but without things like significant mitoses, necrosis, etc. This is essentially irrelevant. Here's an example of a truly high-grade oncocytic carcinoma with 1, 2, 3 mitoses in a single high-power field, a large duct with central necrosis. So these are the things we diagnose as high-grade. Basal cell adenoma is a rare tumor, mostly of the parotid. It is characterized by, as I will show you on the next slide, being very blue with peripheral palisading and eosinophilic hyalinized stroma. I will remind you that basal cell adenoma and basal cell adenocarcinoma share the cylindroma gene that we see in patients with congenital, dermal cylindromas. This is Brooks-Spiegler syndrome. So both genetically and histologically, basal cell adenomas and cylindromas are similar. Some of them also have mutations in the beta-catenin gene. Here's an example of adenoma, clean border, very blue or so-called basaloid, cells with high NC ratios, peripheral palisading at the edges of these nests, and these eosinophilic globules in the stroma. Here's an example of beta-catenin nuclear expression in some basal cell adenomas, so that can help in the diagnosis if you find it, but it is not present. It's not present in all BCAs, just a good percentage. Basal cell adenocarcinoma, has infiltrative growth. Here's an example of a patient with the familial dermal cylindromas, just as a reminder that these are linked. Again, here's my outline of the lobulated invasive tongues of an adenocarcinoma, but on low power, still very blue, still in these lobulated nests, still with peripheral palisading, and still with this eosinophilic membrane material in the center. Depending on the grade of the tumor, it may appear low mitotic activity in bland, or again, it may appear with high mitotic activity and more pleomorphism if it's low versus high grade. But again, infiltrative growth is going to be key. Okay, a very rare tumor of generally the upper lip of an older female is a canalicular adenoma. Here's the tumor outlined on the left with normal salivary gland tissue here. This tends to have 1 to 2 cell layers in cords, but this is not an epithelial and a myoepithelial cell. These are both of the same cell type. You can see these two cords look very similar to each other. No specific genetics, no malignant counterpart, basically upper lip of older females. You can have these, as I said before, these 2 cell thick cords that cluster together and have beating, that have squamous morules in the lumen, that have some myxoid stroma. Characteristically, these are strongly positive for S100, sometimes with GFAP at the luminal edge. All right, now we're going to move on to the tumors that are essentially only malignant, that do not have benign counterparts. So I've listed them here as being multiple cell types or single cell types. As what grade generally are they? So mucoep and adenoid cystic are really the only 2 tumors that have a designated grading scheme of low, intermediate, and high. The rest, you have to sort of use your judgment. Most of them are low, but can have a high grade or dedifferentiated or transformed counterpart. Salivary duct by default is high grade, so there is no sort of low grade counterpart of salivary duct. Intraductal carcinoma and salivary duct carcinoma are not the same, and we will see what those look like shortly. Questions before I move on? Okay, so because this is the most common, we will again spend a little bit of time on mucoep. Remember that this can happen in both adults and children. So kids are not spared from salivary carcinomas. Half of mucoeps occur in the major and half in minor salivary glands. We'll see the 3 cell types, squamoid, intermediate, and mucinous. And we will remember that the genetics are CRTC1 mammal 2 or CRTC3 mammal 2, the common partner here being mammal 2. Here's an example of this gritty kind of white tumor on gross appearance with normal salivary yellowish tissue at the periphery. So mucoep on low power can be solid or can be cystic. We'll talk a little bit how this may or may not impact the histologic grade, but already you can see that there are some pale mucinous cells here. You can see many, many, many large and small cysts in the cystic variant. What you need to see, essentially these 3 cell types, the 2 that you're most commonly going to see are the intermediate and the mucinous. The squamoid can sometimes be hard to identify. The mucinous are, of course, kind of large and ovoid with pale intracytoplasmic mucin. The squamoid have certainly abundant eosinophilic cytoplasm and prominent cell borders, as we would see in squamous cells. And the intermediate are kind of nondescript, in between. They're bland and polygonal. They don't have well-defined cell borders like the squamoid. They don't have such clearing like the mucinous, but they're kind of these very bland, monotonous, nondescript cells. This is in fact the majority cell type you're probably going to see in a mucoep. If you're uncertain whether something in the cytoplasm of these cells is truly mucin versus glycogen, we can do PAS with diastase. So periodic acid Schiff will bind both mucin and glycogen, but only glycogen will be digested by the diastase or so-called amylase, right? So PAS-D. Mucin is diastase or amylase resistant, okay? So PAS will stain mucin and glycogen. Diastase will digest out the glycogen. That is perhaps supportive that this is a squamous cell rather than a mucinous cell. If you see intracytoplasmic mucin with that PASD stain that can be supportive of muco-ep. The 4 grading systems that have been published for MEC are the Healy, the AFIP, the Brandwein, and the Katabi. As you can see, 2 are qualitative and 2 are quantitative. They all take into account similar histologic features like the presence of cysts, perineural invasion, necrosis, mitoses, pleomorphism, et cetera, et cetera, et cetera. Not all features, right, are present in all grading schemes. And what we have found out is that the AFIP tends to assign a given tumor a lower grade, and the Brandwein tends to assign a given tumor a higher grade, with the Katabi and the Healy kind of being intermediate. So if you took the same tumor and graded it with all 4 different systems, you may get, like, I don't know, a grade 1 or a low grade in the AFIP, an intermediate grade in the Katabi and Healy, and a high grade in the in the Brandwein. So this is extremely inconsistent. What we also found, though, was if you score somebody a Brandwein high grade, this is actually the best predictor of bad behavior. If you score someone a low or an intermediate grade on Brandwein, this is the best predictor of a biologically indolent tumor. You can see here various studies have shown low and intermediate grade to cluster more similarly, and high grade to cluster differently. Therefore, we try to not if we call something an intermediate grade, perhaps suggest that biologic behavior is more akin to low, or just eliminate intermediate grade from our terminology and just call it low grade. Because sometimes clinicians don't really know what to do with intermediate grade. Low, yes, we watch, we wait, we observe. High, we do a neck dissection, we may do chemoradiation. But what do we do with intermediate? Probably the same as what we would do with low. Does anybody have any questions on muco-ep? Okay, adenoid cystic is the most common, second most common salivary malignancy, either in the parotid or in the palate as the second most common site. Because these very, very frequently have perineural invasion, right? We know these patients have frequent pain, nerve pain. If you think about it, also because these have frequent perineural invasion, they can be hard to resect because the tumor tracks along the nerves. It can track retrograde into the, up into the kind of base of skull. So these can be very, very challenging to treat. They also have aggressive behaviors and tend to metastasize to visceral sites like lung, like liver, etc., rather than just being retained to the local regional cervical lymph nodes. Adenoid cystic is one of the tumors of 2 cell types, both ductal epithelial and myoepithelial cells. They tend to have dark wrinkled nuclei, and we'll see the patterns. Mostly these have MIB-NFIB gene rearrangements with some various alternate partners as well. So here's an example of that classic cribiform or sieve, or sometimes called Swiss cheese pattern in adenoid cystic. Because adenoid cystic is of epithelial and myoepithelial cells, it is the myoepithelial cells that actually secrete this bluish basement membrane myxoid-like material into the center of these spaces. So this is not really a cyst lined by epithelial cells. This is actually a space lined by myoepithelial cells that secrete the matrix here. If it's predominantly this cribiform pattern, that is considered intermediate grade. Predominantly tubular, as seen here, is low grade. Predominantly solid is high. Here's an example of perineural invasion. And here's an example of the tubular, the cribiform, and the solid patterns. Right? So you can sort of appreciate the differences in architecture, and it's thought that this increasing from tubular to solid growth is predictive of increasingly poor behavior. You can highlight those 2 cell types by immunohistochemical stains. The epithelial cells stain with something like c-KIT, so brown cytoplasmic reaction, cytoplasmic/membranous, versus P63 or P40, which is a brown nuclear reaction. And you can see how the epithelial cells are kind of sandwiched in the middle between the myoepithelial cells on either side. So the myoeps, again, are secreting the material into these central spaces, and they could also be secreting basement membrane material out into the periphery around those cribiform nests. Here's kind of the breakdown of the histologic grade and how they survive. However, even beyond solid adenoid cystic, you can still have increasingly high grade transformation, which is a sort of very pleomorphic mitotically active component arising in an adenoid cystic of any grade. And so here's what they look like. So this is solid, just regular solid adenoid cystic, so-called grade 3, right, where you don't really have too much architecture, but the nuclei are small, round, dark, without prominent nucleoli, without mitoses. However, high-grade transformation, or so-called dedifferentiation of adenoid cystic, is usually still a solid architecture. However, the cytologic features are much worse. Prominent nucleoli, more coarse and open chromatin, mitoses. So this is high-grade transformation or dedifferentiation of adenoid cystic. This will be even worse than the solid. If you just gave me this high-grade slide on high power, I would have no idea that this came from an adenoid cystic, right? So you would have to see some other lower grade or cribiform background or prove the genetics for me to know that this was a D-diff adenoid cystic. Otherwise, it's just a high-grade salivary carcinoma. Probably the most common differential diagnosis histologically with adenoid cystic is polymorphous because of its similar growth pattern with cribiform structures and because of both of their possibility of occurring on the palate. Specifically, the most common location for polymorphous adenocarcinoma is the palate. However, the most common tumor in the palate is not polymorphous. So you can still get adenoid cystic, you can still get pleomorphic adenomas in the palate. So if you have a palate biopsy, don't automatically assume it's polymorphous, but if you have something morphologically that looks polymorphous, it's probably coming from the palate, if that makes sense. In contrast to adenoid cystic, this is of a single cell type, so cytologic uniformity, but architectural or histologic heterogeneity. We tend to see, again, cribiform, we see whorling, we see some single file structures. This can have infiltrative growth as well as PNI. And for the pathologists, it's diffusely S100 positive, but P40 negative. I'll show you why that's important. And this tends to have mutations in PRKD1 gene. Here's an example of that architectural heterogeneity of polymorphous, but the monotony in the nuclei, so oval, open, and vesicular, rather than those dark, wrinkled nuclei of adenoid cystic. Because the differential in a sort of solid, cribiform, tubular tumor, especially in the palate, could range from polymorphous to adenoid cystic to pleomorphic adenoma. We can diagnose polymorphous by its complete absence of P40 on immunostain. So both adenoid cystic and pleomorphic adenoma will retain a P40 positive myoepithelial layer in a component of the tumor. However, polymorphous is completely negative, so very, very helpful in diagnosis. There is a newly proposed cribiform variant of polymorphous, sometimes in the literature referred to as cribiform adenocarcinoma of minor salivary glands. It is morphologically similar. It has similar open nuclei, sometimes referred to as being papillary thyroid carcinoma-like. It has rearrangements rather than mutations of the PRKD1 genes. It tends to occur in the tongue or minor salivary glands outside of the palate. It still has diffuse S100 positivity like polymorphous. However, it more frequently has lymph node metastases. So polymorphous, low-grade carcinoma with PNI, but few lymph node mets on the palate. Cribiform variant, still probably a low to intermediate histologic grade tumor outside the palate, but frequent nodal metastases. And this is perhaps perhaps, we don't really know, related to the location, related to the genetics, but there is morphologic and certainly immunohistochemical overlap. So this is currently lumped in the WHO under the larger term of polymorphous cribiform variant. Moving on to our additional monotypic carcinomas, namely acinic cell, mostly in the parotid gland, sometimes can be of high-grade behavior, gritty kind of white cut surface. You may see by the name that these tumors resemble serous acinar cells, and I will show you what that looks like on the next slide. Genes implicated are listed here. So you can draw a line between normal parotid on the bottom left and acinic cell carcinoma on the top right. The only difference is basically these are sheets of serous acinar cells, no fat, no ducts. Here is our periodic acid shift stain with zymogen granules. The other type of tissue, right, that is resistant to diastase are the zymogen granules. So if you did a PASD, again, these small purple dots would remain, but unlike mucin, it's not just a single globule per cell, right? It's multiple small dots per cell. So zymogen granules are PAS diastase resistant. Here's another example of what high-grade transformation in acinic looks like. So here's some acini on the right of a lower grade component, and here is sheet-like growth with prominent nucleoli and mitoses on the left. Again, looks very similar to that high-grade transformed adenoid cystic, worse prognosis, et cetera, et cetera. I'm going to move on to some of the tumors that are resembling of breast cancer, and this is one of them. So secretory carcinoma, formerly called mammary analog secretory, was described due to its resemblance to juvenile or secretory carcinoma of breast, and it carried the same ETV6 NTRK3 translocation. This is in both parotid and minor salivary glands. It is generally low grade, but can also undergo high grade transformation. On low power, it can have a circumscribed edge if it's low grade. Here it has kind of multiple lobules, and you can already see on low power that there's some kind of material in the lumen. So this can range from a microcystic pattern with pale intraluminal secretions to a papillary pattern with intracytoplasmic vacuoles, sometimes to a hobnail pattern. This was thought to be the microcystic variant of acinic cell carcinoma, but in fact it is morphologically similar but genetically very different. And in fact, if you did a PAS diastase, you would not see zymogen granules within the cytoplasm. You might just see this intraluminal dense secretory material. This is one of the tumors that's diffusely positive for both S100 as well as mammoglobin, and that can be helpful in diagnosis. Here's an example of a high-grade transformation where you have a low-grade circumscribed tumor on the left, which sort of blasts out to a high-grade infiltrative solid fibrotic tumor on the right, ranging from this microcystic low-grade area with secretions to this very solid with necrosis, perineural invasion, high-grade area. So things we like to think about that repeat over and over again in salivary tumors that are high-grade are things like perineural invasion, lymphovascular invasion, necrosis, right? So anytime you see any of those things in a salivary tumor, just consider that it may be a high-grade tumor. The next tumor that resembles a breast cancer is salivary duct. This can arise de novo or out of a pleomorphic adenoma. This is always high-grade. This resembles high-grade DCIS of breast with apocrine cells. We test these for things like androgen receptor and HER2 because often these are positive, and often these can be treated with androgen antagonists or a Herceptin. ER-PR, however, should be negative. If you have ER-PR positivity in a salivary gland tumor, it is essentially diagnostic of a metastasis from the breast, because salivary tumors should not have ER-PR in any significant fashion. Here's what salivary duct looks like with these large spaces, with central cysts, with central necrosis, with cribiform architecture at the periphery, sometimes micropapillary, frequently perineural invasion. Here's your nuclear androgen receptor. Here's your membranous HER2. Most of these that are 3+ HER2 actually do have HER2 amplification. Some of them that are 1 or 2+ do not have HER2 amplification. Moving on to intraductal carcinoma, which formerly was called low-grade cribiform adenocarcinoma. Again, this kind of resembles low-grade DCIS or ADH of the breast. This mostly has intraductal growth, where these nests are surrounded by a myoepithelial layer. Here is an example of that. So we're in a mucosal site. We can see squamous mucosa up here. So we're in a minor salivary gland right here. Multiple cysts with proliferation into the lumen, but P63 or P40 or SMA nicely highlighting the myoepithelial cells. Hence, these are very good prognosis because the entire lesion is contained within the ducts. If you excise it, it's essentially cured because it's usually non-invasive. Some of these can invade, however, but that's rare. Epithelial myoepithelial carcinoma is a rare form of salivary gland cancer, but its histologic features are quite striking, meaning there are these bilayered tubules of epithelial, right, and myoepithelial cells, often with very, very clear myoepithelial cells at the periphery of these ducts. Some of them have HRAS mutations. Here's an example. What does this remind you of? So on low power, it may remind you of that pure myoepithelial carcinoma that we saw earlier, with lobules, with peripheral cellularity, with central necrosis. However, when you look at the areas of peripheral cellularity, you'll see that there are these sheets of cells with clear cytoplasm punctuated by these duct-like structures. Again, duct, I'm highlighting the ducts with my arrow. Hopefully you can see those. So when you see these sheets of myoepithelial cells punctuated by ducts, that is epithelial myoepithelial carcinoma. The other type of cancer that has very prominent clear cells or can have prominent clear cells is clear cell carcinoma, formerly hyalinizing. This tends to happen in minor salivary gland sites like the tongue. It can have stromal eosinophilic hyaline, but it doesn't always have to. Basically, the immunoprofile is essentially of a squamous cell carcinoma, meaning high molecular weight keratin P63, P40, with absence of any other evidence of myoepithelial differentiation. So no S100, no calponin, no SMA, no GFAP. So basically, looks like it kind of could be a myoepithelial carcinoma histologically, but stains like a squame. That's clear cell carcinoma. These have EWSR ATF1 gene rearrangements. That's in fact identical to clear cell odontogenic carcinoma that arises in the jaw. The last one I will mention is lymphoepithelial-like carcinoma, and then, oh good, 9:55, right on time. This sort of looks like a nasopharyngeal carcinoma, meaning non-keratinizing SCC with lymphoid stroma. This is very, very rare. And if you see it, one would want to rule out that the patient does not have a nasopharyngeal mass, meaning it's not a nasopharyngeal carcinoma that metastasized to the parotid. Even in the absence of any nasopharyngeal mass, sometimes these can be associated with EBV. So whether it's an occult nasopharyngeal carcinoma that's not detected, or a true EBV primary parotid cancer is really unknown, but some of them can also be not associated with EBV. These are dense syncytial aggregates of pleomorphic squamoid cells, not always showing evident keratinization, but they should stain with high molecular weight keratin P63. You can see in the background all these cells that are not staining are the abundant lymphocytes, histiocytes, neutrophils, etc. Very prominent nucleoli. So you stick this in the nasopharynx, this is nasopharyngeal carcinoma. You stick this in the parotid, this is this so-called nasopharyngeal-like or lymphoepithelial-like carcinoma. But it is essentially a squamous cell carcinoma in this site as well. The other type of squamous cell carcinoma that can occur in the parotid is a conventional keratinizing squamous cell carcinoma, seen here up at the top. However, it is important for these to consider whether the patient has had a cutaneous primary and consider that this could be a metastasis from a skin cancer to an intraparotid lymph node, just like we would consider a metastasis of a nasopharyngeal carcinoma to an intraparotid lymph node if it has the EBV, right? So squamous cell carcinomas in the parotid, very rare. If keratinizing, consider a metastasis. If non-keratinizing, consider a naso or an oropharyngeal primary. You can prove a cutaneous primary in the keratinizing variants by showing a UV signature spectrum of mutations, such as the C to T base pair changes diffusely throughout the genome. So we've used this in times in our molecular lab to determine whether a tumor is a cutaneous origin or not. And that's all I have for this talk. Does anybody have questions or comments? Thanks for listening.
Thanks so much.
Thank you.